So which of following is a function of lead foil backing in the X-ray film? The answer is all of the above. Well, the function of the lead foiling backing in X-ray film is to shield the film from the scattered radiation. So it primarily serves as shield to protect the X-ray film from the scattered radiation. Scattered radiation, it can result from the interaction of the X-ray beam with the patient body or other objects. So the lead foil, this lead foil would act as a barrier to minimize the impact of scattered radiation on the film, reducing patient exposure. While the lead foil itself does not directly reduce the patient exposure, its role in shielding the film from scattered radiation indirectly contributes to the reducing the patient exposure. Yes, the image quality is also improved by minimizing the effect of scattered radiation and other external factors that can enhance the image quality. So answer here would be all of the above. Moving to the next question. The fastest dental film with speed ranging of f. So the speed ranging from f film, it has a speed range of, the fastest dental film with a speed ranging of x has speed of 48 to 96 round tons. So remember the C film, it has a range of 6 to 12 round tons. The D film, it has range of 12 to 24 round tons. E speed, it has speed of 24 to 8, and F is the fastest one having 48 to 96. So your answer would be C here. So a faster film would require less radiation to create an image. So faster films, they require less radiation. That means the patient, they are exposed to lower dose of ionic radiation during the dental X-ray procedure. With the F films, the dental practitioner can often use shorter exposure time. That is advantageous as it reduces the risk of patient movement during the exposure. That results in sharper and clearer image. Apart from that, there would be less radiations. They can still provide high quality images. The next question, when X-ray interacts with the outer shell electron of atom, it causes ionization and scattering in different direction. So that is the Compton effect. We have already discussed before how to remember the Compton-Thomson and the photoelectric effect. So the Compton scatter, it occurs when the photon, it interacts with the free electron or loosely bound valency shell electron. The energy, they are transferred to the electron and photon is scattered in the different direction. In the photoelectric effect, the interaction occurs with the bound electrons, whereas here it is interaction with the free electrons. Moving to next question, a 25 years old male in your clinic with multiple caries of teeth. After clinical examination, you have decided to do full mouth radiograph survey. How many radiographs they are required for full mouth examination? The answer would be C, 4 bite wings and 17 periapical films. So bite wings, they are used to visualize the interproximal caries and assessing the height of the alveolar bone. Periapical radiographs, they are used for assessing the overall health of the teeth and supporting structure. So this combination of 4 bite wing and 17 periapical film, it is the minimum required for full mouth survey. Radiographic examination shows circular radiolucency around the apex of the mandibular central incisors. So the tooth, it is vital and asymptomatic. So the answer would be periapical. The answer would be cementoma. So it is seen generally in the anterior region. The teeth are often radiolucent. You will see a radiolucency near the periapical region of the mandibular anterior teeth. The teeth, they are generally vital and asymptomatic. Endodontic procedure involving taking multiple radiograph. How should you protect yourself or staff while taking radiograph if there are no barrier available to stand behind? So while taking radiograph in endodontic procedure, if there is no barrier available to stand behind, it is important to stand at least 6 feet away in area that lies at angle of 90 to 135 degree to the X-ray beam. So this position helps to reduce the radiation exposure to yourself or your staff during the radiographic procedure. Apart from that, you can use the faster films like E films or F films for reduced radiation exposure. The next question: what is the error in exposure of this film? So the film shown shows the incorrect film placement for the molar bite wing. What is error in this film? So here you can see is a cone cut. So this region is cone cut. So it occurs when the X-ray cone, it is not properly aligned with the film sensor. So that can lead to cone cut. So it may not provide a clear view of the dental structure. That is the cone cut. The arrow indicates, so this one is the median palatine suture, that is a line of union between two halves of the palatal bone in midline of the root of the mouth. Added filtration in the dental X-ray tube head. So the answer is it results in more penetrating useful beam. So added filtration in dental X-ray machine in path of X-ray beam, it provides between the collimator and tube head seals. This additional filtration, it serves to filter out the short wavelength X-ray from the beam, that in turn results in more penetrating useful beams. So that is why D is correct. Bimolar technique, it is given to which of following view of jaw? It is given for the lateral oblique view of the jaw. So bimolar is the term used for the radiographic projection showing oblique lateral view of right and left side of the jaw on different half of the same radiograph. So this technique, it is used to capture both sides of jaw in a single radiograph while protecting one side from excessive radiation using a lead shield. So remember, the bimolar, it is also known as Gardner view. So that is used to capture lateral oblique view of right and left side of jaw in same radiograph. So you have to give two exposure, the first exposure and the second exposure. In first exposure, the cassette, it is placed so that one side of patient face, it covers half of the cassette with the nodes pointing towards the midline. The X-ray head, it is positioned to capture the designed area, and first exposure is taken. After the first exposure is completed, the lead shield it is placed over the other side of cassette to protect the part of film that has already been exposed. The patient is then repositioned with the cassette held on the other side of face and X-ray tube it is repositioned, and hence a second exposure is taken. So that technique allows for simultaneous imaging of both the sides of jaw while protecting the unexposed portion of film with the lead shield during the second exposure. So that is the bimolar technique. The best view to visualize the zygomatic arches, it's the zug handle view. So this view it is used to visualize the zygomatic arches, and it is a underexposed submental vertex view. The occipitomental view, that is used to visualize the occipital bone and the chin region. OPG is not the answer. Skull PA, it is the posterior anterior view of the skull. Coming to the next question, Mcqs technique, it is also known as a transpharyngeal technique. Transpharyngeal technique, or it is known as Mcqs projection. So the transpharyngeal view it is used for the visualization of the superior portion of the condyle, and it is used for looking at the arthritic changes such as rheumatoid arthritis, or in cases with the degenerative joint disease in the temporomandibular joints. So here the cassette it is placed against the side of the patient, head parallel to the sagittal plane. So this technique it is used for detailed imaging of TMJ, especially the superior surface of the condyle. A radiograph showing 40 years old female revealed a radiolucent area around several of her mandibular teeth. All were tested vital on electronic pulp test. So this area would represent the periapical osteofibrosis. So it is a condition in which there are radiolucent area in bone surrounding the teeth, showing no sign of pulpal involvement or infection. So the answer would be yeah. So these are the radiolucent area of the pulpal osteofibroma. You can see the answer would be B. A cropped OPG image of 25-year-old male. It is suggestive of localized aggressive periodontitis, vertical loss of the alveolar bone around the first molar and incisors, beginning around the puberty. In otherwise healthy teenager, it is a characteristic diagnostic feature of localized aggressive periodontitis. So in the radiograph you will see a arch-shaped loss of alveolar bone extended from the distal surface of second premolar to the mesial surface of the second molar.